as the culprit for increasing cardiovascular disease, but which is not true. And then with more good evidence that we have, including the Carolina trial that recently has come last year, she is going to explain to us how safe our sulfonylureas can be. Dr. Helen Baron specializes in endocrinology, diabetes and metabolism, with additional interest in improving patient care and newer insulins. She has vast experience in pharmacology and insulin therapy and several years of experience in clinical research assistant in projects involving inhaled and injectable newer insulins. Very interesting. She serves as a chair of 7 South ICU Glycemic Control Performance Group, and she's also a task force member in the Medical Error Reduction Team and insulin in the hospital setting. So this is one of the most important things that we do. That, in fact, we are now doing one nurses training program to reduce these errors now. Actually, mostly it happens there actually.
Excellent.
Yeah. Glycemic control and improved outcomes also. So she's honored with the Broadbur Teaching Award and USC Faculty Teaching Award from Los Angeles, California, USA. And we remember you in 2018. You were here in April.
That's
in
right.
our meeting, you spoke about Largine at that time.
And it
It
is
was
an
a wonderful
honor to
talk.
be back.
Yeah.
Thank you so much.
Yeah. And day before yesterday, we heard your erudite lecture as well. So thank you. Yeah.
Thank you. Thank you for that kind and warm introduction. And thank you to all of you delegates for allowing me to be back here today. An absolute pleasure and privilege to stand before you today. And I hope that my conversation can be as passionate and as eye-opening as the one that just preceded me. And to our speaker, my only question is, why don't we have metformin in the water? It appears that it cures all that ails us. So a very exciting, very important, very intriguing lecture. And I really would consider this lecture to be part 2, a continuation, a revisiting of the silent soldiers that stand by our side in the battle of type 2 diabetes. We've heard about the many pleiotropic effects of metformin extending well beyond glycemic control. Well, let us revisit an old friend. Let us discuss the role of sulfonylureas in the patient with multiple risk factors and established cardiovascular disease or heart failure, or as I like to alternatively title this presentation, the world finally catching up to India in terms of treatment of adults with type 2 diabetes. So let us begin. We're going to discuss sulfonylureas. Clearly, this is a topic of old drugs with a new conversation. They've been available for us in the marketplace for more than 5 decades. They are widely utilized. They are perhaps worldwide second only in prescriptions to vitamin M, otherwise known as metformin. They were originally discovered during World War II, well, an offshoot of a discovery in World War II where individuals exposed to sulfa antibiotics were found to have hypoglycemia. And upon further investigation of this, of hypoglycemia, over-insulinization, weight gain, durability, and this question about cardiovascular risk. In fact, the UGDP in 1970 reported an increased risk of cardiovascular mortality with the first generation sulfonylurea, tolbutamide. However, this study has been criticized, in particular looking at the sex ratio of CV deaths amongst the placebo-treated patients, cardiovascular mortality reported in patients with FPGs greater than 200 who should not have been receiving tolbutamide, and reported absence of chronotropic effects with tolbutamide, which had earlier been reported. Glimepiride is a third-generation novel sulfonylurea, has a unique mechanism of action. Not all sulfonylureas were created equal. With conventional sulfonylureas, they bind strongly to the sulfonylurea receptor, the 140 kilodalton protein, and cause a continuous and constituent release of insulin regardless of whether the patient is in the fed or the fasting state, regardless what their serum blood sugar is. These can contribute to hypoglycemia and weight gain. Glimepiride, alternatively, binds to a distinct, smaller 65 kilodalton protein site on the potassium ATP channel of beta cells. And what unique advantage does this confer? A significantly increased rate of binding to the sulfonylurea receptor, but also a significantly increased rate of dissociation. So you have enhanced rapidity of binding, activation of insulin secretion from the beta cell, and then dissociation. allowing to robust and immediate release of insulin and then some time off. We see the benefits of this novel third-generation sulfonylurea in terms of lower risk of hypoglycemia, preservation of beta cell function, prevention of early secondary failure of sulfonylureas, less weight gain, and avoiding, potentially, the atherogenic effects of hyperinsulinemia. This brings us to several benefits. Inexpensive, allowing for once daily dosing, reliable glucose control, well tolerated, rarely causing side effects other than the purposeful effect of glucose lowering, and pleiotropic benefits, perhaps not to the extent of metformin, but a close second. CV safety of sulfonylureas can be assessed on the following parameters at a minimum: cardiovascular mortality, myocardial infarction or stroke, and hospitalization for acute coronary syndrome and urgent revascularization procedure. Let's talk briefly about sulfonylureas and their association with reduced risk of cardiovascular mortality. Specifically, let's discuss glimepiride. Sulfonylureas, especially with latter generation modern sulfonylureas, are a safer bet. Here we see forest plots for cardiovascular mortality of sulfonylureas according to comparator, which for the most part in clinical trials exist either as placebo or therapeutic lifestyle changes, if not an active comparator. And we see second and third generation sulfonylureas are not associated with an increased risk of all-cause mortality, cardiovascular mortality, MI, or stroke. Again, not all sulfonylureas were created equal. Although they share a name by classification, really, when we're talking about the true sulfonylurea usage and uptake currently, second and third generation, we're dealing with effective and safe medications. Here we see the comparison of CV-related mortality between sulfonylureas using both direct and indirect evidence from clinical trials. We can see here that glimepiride and gliclazide are associated with lower risk of all-cause and CV-related mortality compared to glabeclamide, with a 21% reduction at glimepiride. Here we're looking at the 3-year mortality benefits in adults with type 2 diabetes treated with different insulin secretagogues plus metformin. And as you can see in the uppermost line in the Kaplan-Meier analysis in gold representing glimepiride and gliclazide, we see greater selectivity for beta cell receptors and association with lower mortality when used in combination with metformin. Sulfonylureas in and of themselves have a low risk of myocardial infarction. Here's VADT-FS study, follow-up of glycemic control in adults with type 2 diabetes. And we can see here the plots of time to first major cardiovascular event and death from cardiovascular causes. Please note that intensive therapy group with glimepiride had a significant 17% relative risk reduction in major CV events compared to standard therapy. So we're really starting to put into our trials and our analysis that which we realize in clinical practice. When we make wise decisions about the sulfonylurea you use, we choose a second or a third generation sulfonylurea. Start at a low dose, titrate as appropriate in an attempt to just achieve good glycemic control without undue risk of hypoglycemia. These medications are not only efficacious, but they come with safety, cardiovascular safety. And why can we postulate could this be happening? Well, modern sulfonylureas do not alter ischemic preconditioning. Modern sulfonylureas do not inhibit the mitochondrial potassium ATP channel opening in cardiac myocytes to the same degree that early first generation sulfonylureas did. Therefore, they preserve the protective myocardial ischemic preconditioning. In fact, in this study, we can see that glimepiride maintains ischemic preconditioning. Here we're looking at repetitive balloon occlusion and testing to see the degree of ST segment elevation, basically bringing forth a level of ischemia. We can see a 34% reduction in mean ST segment shift in the glimepiride group, on par with placebo, but as opposed to the glimeclamide group, in which there was no change in ST elevation, thus indicating that glimepiride maintains ischemic preconditioning, which can be a protective event in terms of a coronary artery occlusion. Glabeclamide, however, prevents this protective ischemic preconditioning. Advanced trial, cardiovascular safety of the modern sulfonylurea glicoside. So this was a tremendous trial that really was starting to turn information on its head, not just recognition of our own clinical experience, that with second and third generation novel sulfonylureas, we're not seeing the same rate of cardiovascular risk, but here to actually put forth in a meaningful statistical analysis with advance. Here we see intensive glucose control with gliclazide, the modified release version, plus other drugs, reduces the incidence of combined primary outcome of major macrovascular or microvascular events by 10%. Sulfonylureas have low risk for hospitalization, for ACS, and urgent revascularization procedures. In fact, it just so happens that in terms of cardiovascular safety of sulfonylureas and in-hospital mortality benefits in this given study, inpatient mortality was least amongst patients who were on sulfonylureas prior to admission when compared to those individuals on insulin, those individuals not on any anti-diabetic medication, or those individuals on other oral units, not including sulfonylurea. In-hospital mortality amongst patients who received SUs before admission was lower than that of patients without such treatment. And glimepiride preferred sulfonylurea in those with underlying CAD. And here we can see that glimepiride could be considered a preferred sulfonylurea in individuals with type 2 diabetes with underlying CAD in terms of lower rates of overall mortality compared to glipizide and glyburide. Initiating treatment of type 2 diabetes with newer SUs reduces the risk of CAD. And CAD, ischemic heart disease, structural heart disease, these really are the points of intrigue in the current field of diabetology. And be us medicine physicians, diabetologists, endocrinologists, at the end of the day, we are all de facto junior cardiologists. Because what use is it to apply medical therapy to treat hyperglycemia if the pump is not there to circulate said medication? So cardiovascular safety of sulfonylureas in hospital complications. In-hospital complications, including rhythmic ischemic complications, less frequent in patients previously receiving glicozide or glimepiride, as you can see here in the pink or orange bars, versus glabeclamide in the green bars, in terms of any complication, arrhythmias, reinfection or stroke, or death. Let's move on to discuss CVOTs with sulfonylureas in their treatment and control arms. This is a wonderful article from the Indian Heart Journal, accepted January 5th, currently in the proofreading stage, unraveling the utility of modern sulfonylureas from CVOTs and landmark trials. Expert opinion from an international panel. And what do we say? For all the potential theoretical consternation of sulfonylureas and association with coronary artery disease, please note that in these major landmark studies, the utilization of sulfonylurea in the comparator arms, in the active arms, ranged anywhere from 30 to 50%, really reflective of our true practice. CVOTs with glimepiride is a direct comparator. Tosca IT. Sulfonylureas are as good as pioglitazone. Here we see the incidence of cardiovascular events similar with SU, in particular glimepiride and glicozide, and pioglitazone as add-on treatments to metformin. Fantastic news, my colleagues, because never forget our first order priority in medicine, which is to first do no harm. Carolina study, trial study design. After a screening visit and placebo run in patients randomized to receive either linagliptin once daily at 5 milligrams, a DPP4 inhibitor, or the modern third generation sulfonylurea glimepiride 1 to 4 milligrams daily. The length of the study was variable as it was event-driven based on MACE outcome, and afterwards there was a 30-day follow-up after the event. Carolina was designed to include participants with relatively early type 2 diabetes and increased cardiovascular risk, really to mimic the patient population that we frequently see. The median duration of diabetes in this trial was 6.2 years. However, over a third already had established cardiovascular disease. 37% displayed at least 2 defined cardiovascular risk factors. 41% had type 2 diabetes for 5 years or fewer. They all received standard of care for cardiovascular disease. 83% were on metformin at time of enrollment. No patients were on insulin. 9% of patients were treatment naive. This was presented at the American Diabetes Association Scientific Sessions last year, June of 2019, in San Francisco, California. The results were published online in JAMA, September 19th, 2019, with the conclusion being, amongst adults with relatively early type 2 diabetes and elevated cardiovascular risk, the use of linagliptin compared with glimepiride over a median of 6.3 years resulted in non-inferior risk of composite cardiovascular outcome. Allow that for a moment to sink in. Really, the tremendous benefit we believe with the DPP-4 inhibitors is that they provide a mild degree of glycemic improvement, but really are relatively asymptomatic. And in particular, we don't see statistical significant evidence of any increase of cardiovascular events. To show that these two arms were comparable, linagliptin and glimepiride, is fantastic. In fact, Carolina cardiovascular outcomes demonstrates non-inferiority in both 3-point MACE and 4-point MACE for both linagliptin versus glimepiride, with 3-point MACE including cardiovascular death, non-fatal MI, non-fatal stroke, and 4-point MACE including hospitalization for unstable angina. In terms of metabolic outcome, at the end of the 6 years, there was no statistical difference. As one would expect, there was a more rapid and robust drop in hemoglobin A1C in the glimepiride arm, and both arms trailed up over the next 5 to 6 years. There was no statistical difference between the groups. Body weight outcomes. Originally, in the first couple of years of the study, there was weight gain with glimepiride, at max just over 0.5 kilograms. But then, after the first couple of years in the study, the glimepiride group plateaued in their weight gain and actually began to lose weight, such that by the end of the study, both arms had weight loss. Summary of safety outcomes. And I apologize for the typo. It should say hospitalization for heart failure was at 3.7% for linagliptin. Hypoglycemia, 27 episodes in glimepiride arm versus 2 in the linagliptin arm. Heart failure, 112 versus 92, favor of linagliptin. Outcome summary. In terms of efficacy, no statistically significant difference in A1C between glimepiride and linagliptin. Although with the glimepiride group, clearly we saw a more rapid and robust hemoglobin A1C reduction within the first 4 months of therapy. In terms of safety outcomes, equivalent, no significant AEs or dropouts. Hypoglycemia. And I really believe that this point should be highlighted. There were more episodes of hypoglycemia in the glimepiride arm than the linagliptin arm, about 3 times more common. Yet, this did not translate in any increase in cardiovascular events. No difference in 3-point MACE, no difference in 4-point MACE, no difference in cardiovascular safety, cardiovascular mortality, all-cause mortality. This is tremendous. Not only are not all sulfonylureas created equal, but apparently the hypoglycemia that comes with them, not all created equal. Weight gain, both medications had weight loss at baseline, from baseline to the end of the study, with more weight loss in linagliptin arm. 3-point MACE, 4-point MACE, all-cause mortality, no statistically significant differences. There was no statistically significant difference in hospitalization for heart failure either, although a numeric trend favoring glimepiride as opposed to linagliptin. Recommendations from the ADA in regards to the Carolina trial. Cardiologists everywhere, including us, junior de facto cardiologists, can be reassured about the cardiovascular safety of glimepiride. Now, whether this extends to other modern sulfonylureas has yet to be determined. But based on the totality of the data of both Carmelina and Carolina, the FDA should revisit the specific novel third-generation sulfonylurea glimepiride and assess the product label warnings for removing increased cardiovascular mortality as a warning. Carolina has helped to resolve the decade-long uncertainty of the cardiovascular safety of sulfonylureas, particularly glimepiride. We've come a long way from UGDP with ADOPT, ADVANCE, UKPDS, TOSCA IT, and now Carolina. No difference in the incidence of cardiovascular events with linagliptin versus glimepiride. So to sum up my key messages, owing to a growing concern on the adverse CV outcomes in trials of some anti-diabetic agents, The FDA has mandated going forward CVOTs with all products. Modern sulfonylureas do not inhibit mitochondrial potassium ATP channel, opening the cardiac myocytes, thereby preserves myocardial ischemic preconditioning, and perhaps this contributing to the mechanism of action by which we do not see the same rate of cardiovascular adverse reactions with modern sulfonylureas such as glimepiride, even when there is hypoglycemia. Second and third generation SUs are not associated with increased risk of all-cause mortality, CV mortality, MI, or stroke. Modern SUs are preferred for efficacy and safety, in particular cardiovascular safety. And the published Carolina data has retreated the cardiosafety specifically of glimepiride. Thank you, my colleagues, for your kind attention.
Thank you for defending that sulfonylurea amidst that the newer drugs. Really, because people are after this advent of these newer drugs, people, as my co-chairman Dr. Vijay Kumar said, that is practitioners are little reluctant to use this sulfonylurea, and you have cleared the doubt, and I think it has certainly got an advantages with respect to easy availability and also the cost, which is a more important factor in Indian scenario. So once again, we thank for your nice talk.
Thank you so much.
Yeah, we'll have a discussion after the next
Fantastic.
next lecture. Yeah. Thank you very much.